Myocardial ischemia, acute myocardial ischemia. For this, we will consider a patient with atherosclerotic narrowing of the coronary vessels. He is comfortable at rest, but on exercise gets anginal pain. What happens is that after exercise, the myocardial demand increases, but sufficient blood cannot reach the myocardium due to partially obstructed coronary arteries. So there is acute myocardial ischemia, seen on the ECG in the form of ST segment depression, which disappears with rest when the demand reduces. This ECG in lead V5 shows a ST depression of 2 mm during an attack of angina. The same lead in the same patient after a few hours shows isoelectric ST segment. This is the typical change in angina pectoris. There is plain or downward sloping ST segment depression which is temporary. Now compare the effect of myocardial infarction as seen on the right. When a coronary vessel gets blocked causing an infarct, ECG shows ST segment elevation in the leads facing the infarcted area. While in acute myocardial ischemia, as seen on the left, ECG shows a temporary ST segment depression. Acute myocardial ischemia is also seen during stress test or exercise test. In a positive stress test, there will be a depression of ST segments in the leads facing the ischemic area. The changes are most prominently seen in V5 and V6. In this ECG, the ST segment shows a horizontal and downward sloping depression of 1 mm after exercise. This is a positive sign of myocardial ischemia. The criteria for diagnosing myocardial ischemia are: number 1, the J point should be depressed by at least 1 mm, and number 2, the depressed ST segment should be horizontal or downward sloping but not upward sloping. Only if the J point depression is more than 2 mm, then upward sloping ST segment may be considered as pathological. Just as in myocardial infarction, if these changes are seen in leads 1 AVL V4 to V6, it indicates ischemia of the anterior wall of left ventricle. And if these changes are seen in leads 2, 3 AVF, it indicates ischemia of inferior wall. But if more than one coronary vessels are blocked, the changes will be seen in many leads. For example, in this strip, they are seen in 2, 3 AVF as well as V4, V5 and V6. The ischemic changes are never seen in leads V1 and V2. The ST segment depression in leads V1 or V2 may be seen only in right ventricular hypertrophy with strain and in true posterior wall infarctions. At this stage, let us see the various types of ST segment depressions. This is horizontal or plain ST segment depression with sharp angle with the T wave. This signifies myocardial ischemia. This is a upward sloping ST segment depression and is a variant of normal. It is significant only if the J point is depressed by 2 mm or more. This is called horizontality of ST segment, where the ST segment remains absolutely horizontal and isoelectric and makes a sharp angle with the T wave. This is an early manifestation of ischemia. This is a downward sloping ST segment which indicates severe ischemia, but it is also seen in digitalis toxicity. This is a sagging concave upwards ST segment, also suggestive of ischemia. Non-acute myocardial ischemia. Note the slight ST depression and symmetrical T wave inversion in lead V5 of this ECG. In acute ischemia, we saw that the patient with narrowed coronary arteries shows ST segment depression during stress test and during anginal attack. But if the ECG is taken at rest when there are no symptoms, what will we see? In many of the patients, there will be no change at all. That is, the ECG of a patient with partially obstructed coronary arteries may be perfectly normal. But in others, some ischemic changes will be present. The commonest change is slight ST segment depression and inversion or flattening of the T waves in leads V5 and V6, just like the strain pattern in left ventricular hypertrophy. So if the leads V5 and V6 show ST segment depression and flat or inverted T waves in a patient without left ventricular hypertrophy, myocardial ischemia should be suspected. The second change that may be seen is inversion of T waves in anterior or posterior limb leads. Note the T wave inversions in leads 2, 3 and AVF. In the absence of chest pain or infarct, T wave inversion suggests myocardial ischemia and their location suggests the area of ischemia. So this ECG suggests ischemia of the inferior wall, that is, narrowing of posterior descending branch of right coronary artery. So to summarize, non-acute ischemia may be diagnosed from ST segment depression in leads V5 and V6 with flattening or inversion of T waves and T wave inversion in limb leads. Arrhythmias. Arrhythmia is a disturbance in the rhythmic contractions of the atria and ventricles due to disorders in impulse production or impulse conduction. The disorders in impulse production may result in arrhythmias like premature beats, non-sinus rhythms, tachycardias, bradycardias, fibrillation and flutter. Disorders in impulse conduction may result in partial or complete heart block or AV block, right and left bundle branch blocks, WPW syndrome, and sinus pause with escape beats. Now we shall study these arrhythmias in details one by one. Premature beat is a beat arising from an ectopic focus outside the SA node and occurring before the next sinus beat. It may arise in the atria, AV node or in the ventricles because pacemaker cells are located in the atria, AV node, bundle of His and Purkinje fibers in the ventricles. In this strip, a premature beat has occurred after beat number 2. As a result, the expected sinus beat number 3 is missed and after a small pause, the next sinus beat number 4 comes and the sinus rhythm starts again. The pause between the premature beat and the next sinus beat is termed as the compensatory pause, and it compensates for the early occurrence of the premature beat. If it compensates exactly for the missed beat, and the third sinus beat occurs exactly where it would otherwise have occurred, then it is termed as a complete compensatory pause. Observe this strip carefully. The red spots mark the expected occurrence of P waves and the black line at the top marks the expected occurrence of the R waves, that is, if the sinus rhythm was undisturbed. You will note that the beat after the premature beat has occurred exactly where it should have occurred. So this is a complete compensatory pause. In contrast, in this tracing, the beat after the premature beat has occurred before the next expected beat. So this is incomplete compensatory pause. To study the compensatory pause, count each RR interval. The first normal RR interval is 20 small squares. The RR interval of the premature beat is 14 small squares. And the RR interval of the compensatory pause is 23 small squares. The two added together, 14 plus 23, is 37 small squares, whereas it should have been exactly 2 times the normal RR interval of 20 small squares, that is 40 small squares. So this is an incomplete compensatory pause. Ventricular premature beats have a complete compensatory pause, as the impulse arising in the ventricles does not affect the rhythm of the SA node. In contrast, an impulse arising in the atrium will depolarize the SA node early, disturbing its rhythm, and hence the next impulse from the SA node will come earlier than the expected next beat. The premature beat always arises outside the SA node, so it is also termed as ectopic beat or extrasystole. It may arise anywhere in the heart, the common sites being atria, AV node or ventricles. Depending on the site of origin, the premature beat is termed as supraventricular or ventricular. The atrial and nodal premature beats are termed as supraventricular premature beats. In these beats, the impulse will reach the ventricles via the normal conduction pathway. So the QRS complex on ECG will have a normal configuration. This is a nodal premature beat. But if the impulse arises below the division of bundle of His, in one of the bundle branches or in the ventricles, then both ventricles will not be activated at the same time, resulting in a wide, slurred and bizarre QRS complex with T wave directed opposite to the main QRS complex. It is grossly different from the normal beats. This is a ventricular premature beat. Compare it with the normal beat and note the wide QRS with inverted T wave. Once again, note the features of a ventricular premature beat. The QRS complex is wide and bizarre, and the T wave is opposite in direction to the main QRS complex. So let us now study the differences between ventricular and supraventricular or atrial premature beats. Number 1. The atrial premature beat has normal QRS configuration, while ventricular premature beats have a wide and bizarre QRS complex. Number 2. The atrial premature beats have incomplete compensatory pause, whereas ventricular premature beats have a complete compensatory pause. Number 3. Ventricular premature beats have no P wave. A preceding P wave is seen only in supraventricular premature beats, though it may not always be visible. It may be merged with the previous T wave. When QRS complex of the premature beat has normal configuration, the beat is supraventricular. Its site of origin can be determined by studying the P wave. In this premature beat, the P wave is similar but slightly different from the other sinus beats. So this is an atrial premature beat. Note the upright P wave slightly altered in an atrial premature beat. The PR interval is normal. In this ECG, the premature beat shows an altered P wave different from the regular sinus P waves. So this is an atrial premature beat. This premature beat has an inverted P wave with a very short PR interval. This is a nodal premature beat. The P wave is inverted as the impulse travels in the reverse direction in the atrium, and the PR interval is short because the nodal delay in conduction is eliminated. Inverted P wave and short PR interval. In this ECG, note the upright P wave of the previous sinus beat and inverted P wave of the premature beat indicating nodal origin. This premature beat has no P wave. This is also a nodal premature beat. If the impulse arises in the lower part of the AV node, the P wave will be delayed and may occur with the QRS complex or even after the QRS complex. In this case, it has occurred with the QRS complex and hence it is not seen or absent. Sinus pause and escape beats. When we studied the premature beats, we saw the sequence of a premature beat followed by a compensatory pause. But if you see the upper strip of this ECG carefully, There is a pause between beats 2 and 3, but the preceding beat number 2 is not premature. That means the SA node itself paused for a while and then started beating again. This condition is termed as a sinus pause. A compensatory pause was preceded by a premature beat, while a sinus pause is preceded by a normal beat. Now measure the RR interval, and it is 30 small squares, that is 1.2 seconds. It has no relation whatsoever to the previous RR intervals. And after the pause, normal sinus rhythm has started again. So this is a sinus pause, a pause following a normal sinus beat. In this tracing, once again we see a pause following a normal beat number 2. Now measure the RR interval, and it is 40 millimeters or 1.6 seconds. If the sinus pause is longer than 1.5 seconds, then it is termed as sinus arrest. This is sinus arrest. When sinus arrest occurs, the SA node may recover and resume the function again, as has occurred in this case after 1.6 seconds, or if it doesn't, then some lower ectopic focus will fire an impulse and stimulate the heart. It will be worthwhile remembering here that there are several pacemaker cells capable of firing impulses in the atria, AV node, bundle of His, and Purkinje fibers in the ventricles. But SA node is the fastest and most dominant pacemaker, which does not normally allow any other cell to fire the impulses. But when sinus arrest occurs, the lower centers temporarily escape from the depolarizing impulses of the SA node, and one of them fires an impulse till SA node takes over again. So if this beat following the sinus arrest comes from one of the lower pacemakers, it is called as an escape beat, indicating an escape from the inhibition of the SA node. A careful study of the beat after the sinus pause will tell you the origin of the escape beat. This ECG shows a pause with a preceding normal sinus beat and normal T wave. The escape beat shows a slightly altered P wave and normal QRS complex. So this is a sinus arrest with atrial escape beat. Note the slightly altered P wave of the atrial escape beat. This ECG shows a pause with a preceding normal sinus beat and normal T wave. The escape beat shows an inverted P wave very close to the QRS complex, which has normal configuration. So this is a nodal or junctional escape beat. A nodal escape beat may also show absent P wave. It occurs after a pause of 1.2 to 1.6 seconds. This ECG shows a sinus arrest with ventricular escape beat. Note the preceding normal sinus beat and normal T wave. Then note the escape beat, which has no P wave, wide and bizarre QRS complex, and T wave in opposite direction. So this is a ventricular escape beat. A ventricular escape beat occurs after 1.8 to 2.2 seconds. So to revise, whenever you see a pause, first study the preceding beat. If it has occurred early, as in the upper strip, it is a premature beat with compensatory pause. And if the RR interval is normal, as in the lower strip, then it is a sinus pause with an escape beat. Now if it is a premature beat, study the QRS complex, compensatory pause, and P wave to decide the origin of the premature beat. And if it is a sinus pause, study the succeeding beat to know the type of escape beat. Now before we conclude this chapter, we must see two more peculiar ectopic beats. Here the arrow shows a ventricular ectopic beat. But if you study the normal QRS complex rhythm, it is unaltered. That is, this is an extra beat in addition to the normal sinus rhythm. Till now we saw that the sinus beat following an ectopic or premature beat is missing. But here The ventricular premature beat has occurred so early that it did not affect the AV node, which conducted the normal beat as usual. This is called as an interpolated ventricular premature beat, usually seen with bradycardia. The only effect that it has on the next beat is that the PR interval is prolonged, delaying the QRS complex slightly. Otherwise, the sinus rhythm is undisturbed. Note the prolonged PR interval in the succeeding beat. This is another interpolated ventricular premature beat. Note that the sinus rhythm is undisturbed. In a close-up view, note the prolonged PR interval of the succeeding beat. This second tracing shows a pause. The previous beat is not premature and it looks like a sinus pause. But if you observe the previous T wave carefully, it shows a dent caused by P wave. Here, an atrial premature beat has occurred so early that it was not conducted by the AV node, which was still in a refractory phase. This is a non-conducted atrial premature beat. It looks exactly like sinus pause, but the last T wave shows a dent or alteration. This also means that to diagnose a sinus pause, the previous T wave contour should be normal. In this tracing, note the change in the shape of T wave due to P wave of the non-conducted atrial premature beat. Only close observation will tell that this is not a sinus pause. This ECG shows a nodal premature beat with inverted P wave, normal QRS complex followed by a compensatory pause. The compensatory pause in a nodal beat may or may not be complete. This ECG shows a ventricular premature beat with no P wave, wide QRS complex and inverted T wave. The RR interval is 18.5 small squares. The RR interval between second and fourth beats is 37 small squares. That is, the compensatory pause is complete. This is because it does not affect the SA node. This ECG shows multiple ventricular premature beats. There is a ventricular premature beat after every 2 normal sinus beats. Multiple ventricular ectopic beats, more than 5 per minute, may herald a ventricular tachycardia. The high risk is associated with multiple VPBs more than 5 per minute, multifocal ventricular premature beats, runs of ventricular premature beats, and exercise-induced ventricular premature beats. This ECG shows multiple ventricular premature beats, but some are positive and some are negative. That is, they are arising from different foci in the ventricles. They are called multifocal ventricular premature beats. Each ventricular premature beat has a different structure. Some are positive and some are negative. This ECG shows alternate normal beat and ventricular premature beat. This is called ventricular bigeminy, where every alternate beat is a ventricular premature beat. Note the ventricular bigeminy. This is the same ECG in another lead. Note alternating normal beats and ventricular premature beats. This is another ECG of ventricular bigeminy with alternating ventricular premature beats. This is an interpolated ventricular premature beat. Note that the shape and amplitude of the QRS complex is changed, so it is a ventricular beat, and succeeding beat is slightly delayed due to prolongation of the PR interval. This ECG shows one normal beat followed by 2 ventricular premature beats. When ventricular premature beats run in groups of 2s or more, it is also a grave sign. Note the runs of ventricular premature beats. This ECG shows a pause. The preceding beat is not premature. Preceding T wave is normal. So this is a sinus pause. So now we study the succeeding beat. It has a normal QRS configuration, but the P wave is slightly smaller than other P waves. So this is an atrial escape beat. Note that the next beat again shows return of sinus rhythm as the P wave is normal again. So this is a sinus pause with an atrial escape beat. Now that we have learnt all types of premature beats and escape beats, let us proceed to various rhythms arising from the SA node, atria and ventricles. Abnormalities in SA node rhythm may be in the form of sinus arrhythmia, sinus bradycardia and sinus tachycardia. Sinus arrhythmia. Normally, the heart rate increases slightly during inspiration and decreases during expiration. This variation is termed as sinus arrhythmia. Sometimes the variation may be so marked that it may be confused with pathological arrhythmias. In this ECG, which is a continuous strip, the RR interval varies from 16 small squares in expiration to 22 small squares in inspiration. But you will note that all PQRST complexes are normal. Each QRS complex is preceded by a P wave with fixed PR interval. This indicates sinus rhythm. So now we know the features of normal sinus rhythm. Number 1, the P wave morphology should be normal. Number 2, the PR interval should be normal and constant. And number 3, each P wave should be followed by a QRS complex. In such a case, if the heart rate is below 60 per minute, that is RR interval is more than 25 small squares, it is termed as sinus bradycardia. In this ECG, the RR interval is 34 millimeters. So the heart rate is 44 per minute. P wave, PR interval and QRS are normal, indicating sinus rhythm. So this is sinus bradycardia. This is another recording of sinus bradycardia with heart rate of 33 per minute. The RR interval is 45 millimeters. Note the normal P waves and normal PR intervals. Sinus bradycardia is seen in athletes during sleep and with drugs like beta blockers. Sinus tachycardia. If the sinus rate is above 100 per minute and up to 150 per minute, it is termed as sinus tachycardia. In this ECG, the RR interval is 12 millimeters, so the heart rate is 125 per minute. The T wave and the next P wave are seen very close together. The practical problem that arises at high rates is that the P waves and the previous T waves mix up and P waves become difficult to identify. In this ECG, the RR interval is 10 millimeters, so the heart rate is 150 per minute. Now see the upper tracing of V5. It is very difficult to identify the P wave, but if you observe all leads carefully, the P waves are usually identified in at least one of the leads, as seen in lead V1 in this case. So careful inspection of all the leads for P waves becomes very important in tachycardias to identify a P wave. Now we shall study atrial rhythms, which includes atrial rhythm, wandering pacemaker, supraventricular tachycardia, atrial flutter and atrial fibrillation. This ECG shows lead 2 tracing with inverted P waves, that is, the impulse is arising low in the atrium and travelling backwards. This is termed as non-sinus atrial rhythm. A rhythm arising from the AV node will also give a similar appearance with inverted P waves, but the PR interval in nodal rhythm is very short. In this ECG, the PR interval is more than 3 small squares, So this is an atrial rhythm. This is another atrial rhythm, but observe the P waves carefully. Each P wave has a different contour, which means that each impulse is arising from a different focus in the atrium, and accordingly the PR interval also varies slightly from beat to beat. This is called as wandering pacemaker, sometimes seen in children and is harmless. Observe the P waves in this tracing of wandering pacemaker. Note that contour of each P wave is different, indicating a different focus for each impulse, but the QRS complexes are normal and constant. This ECG shows tachycardia. The RR interval is 7 millimeters, so the rate is 210 per minute. This is much above the range of sinus tachycardia and is termed as supraventricular tachycardia or paroxysmal atrial tachycardia. This is another ECG of tachycardia with a rate of 200 per minute. Note that the QRS morphology is normal, so it is supraventricular. In the supraventricular tachycardias, the rate varies from 180 to 220 per minute. In this ECG, the RR interval is 8 millimeters, so the rate is 188 per minute. But often, the AV node may not be able to pass down the impulses to the ventricles so rapidly, and then it starts passing down every second or every third impulse. This is termed as 2 to 1 block or 3 to 1 block. In this ECG, you will immediately note that there are many more P waves than QRS complexes. Count them. Every second P wave is followed by a QRS complex. In this case, we must count the atrial rate separately as 1500 divided by the number of small squares between two P waves, and ventricular rate separately as 1500 divided by the number of small squares between two R waves. The atrial rate here is 166 per minute, indicating supraventricular tachycardia, and ventricular rate is 83 per minute, indicating 2 to 1 block. That is, in a 2 to 1 block, ventricular rate is exactly half the atrial rate. So clinically, a patient with supraventricular tachycardia with block will not have a rapid pulse rate. Only ECG will demonstrate the atrial rate to be about 160 to 220 per minute. In this ECG, the P waves are very large and rapid, and the rate is about 300 per minute. This condition is called atrial flutter. Here, the impulses travel in a circular course in the atria, giving rise to rapid, regular, and undulating flutter waves. These are not P waves, but flutter waves or F waves. Capital F stands for flutter waves. Each flutter wave occupies one large square. So these are much wider and taller than the P waves, and there is no isoelectric baseline between them. Looking from a distance, it gives a classical sawtooth appearance. This is best seen in leads 2, 3, AVF, V1 and V2. Since AV node is not tuned to conduct impulses so fast, atrial flutter is always accompanied by AV block, and the ventricular rate is much slower. Here the flutter rate is 300 per minute, and this ECG shows 2 to 1 block, so the ventricular rate is 150 per minute. Note that each F wave occupies one large square. This is again a 2 to 1 block. This ECG shows 3 to 1 block with ventricular rate of 100 per minute. And this ECG shows 4 to 1 block with ventricular rate of just 75 per minute. Note that the ventricular rate and the pulse is regular, but sometimes the flutter may show a varying block and irregular pulse. Atrial fibrillation. In this ECG, The QRS complexes are seen at irregular intervals. There are no P waves preceding the QRS complexes, and the baseline is finely irregular as if vibrating. This is atrial fibrillation. Note the finely irregular baseline and irregularly occurring QRS complexes. This ECG shows irregular rhythm. Fibrillation waves are not seen, but very notable feature is the absence of P waves. This is atrial fibrillation. In atrial fibrillation, the impulses follow chaotic random pathways in the atria. So there are no P waves, but the baseline shows irregular fine waves termed as fibrillation waves or F waves. Small f stands for fibrillation waves. We have already learnt how to calculate the rate in atrial fibrillation. Measure the number of R waves in 15 large squares and multiply the number by 20. Here the rate is 5 into 20, that is approximately 100 per minute. In this ECG, the rate of QRS complexes is reduced after treatment with digitalis, but they occur at irregular intervals and fine fibrillation waves are seen. This is termed as slow atrial fibrillation, an effect of digitalis treatment. The fibrillation waves are described as fine, medium or coarse. These are fine fibrillation waves. These are medium fibrillation waves. And these are coarse fibrillation waves. Coarse fibrillation waves at times resemble atrial flutter, and a mixed pattern with characteristics of both is seen as in this strip. This is termed as flutter fibrillation. It has no clinical significance, just an ECG manifestation of atrial fibrillation. Note that each F wave occupies less than 4 small squares. So the rate is around 400 per minute, which is beyond the range of atrial flutter. So this is not flutter but flutter fibrillation. Nodal rhythm, also termed as junctional rhythm. When the impulses originate in the AV node, the rhythm is termed as nodal rhythm. The heart rate with nodal rhythm is very slow, about 40 to 60 per minute. This ECG shows a heart rate of 1500 divided by 26, that is 58 per minute. The QRS complex is normal, indicating supraventricular origin, and the P wave is inverted with a very short PR interval of 2 small squares or 0.08 seconds. This is called upper nodal rhythm. This ECG is similar with heart rate of 60 per minute. QRS complex is normal and there is no P wave as it is merged in the QRS complex. This is called as mid-nodal rhythm. This is again a nodal rhythm with slow heart rate, but P waves occur immediately after the QRS complexes. This is called as lower nodal rhythm. So the characteristics of a nodal rhythm are: number 1, slow rate of 40 to 60 per minute and inverted P wave just before, within or just after the QRS complex. This ECG shows inverted P waves in leads 2 and 3 with short PR interval, indicating a nodal rhythm, but the rate is 100 per minute, beyond the normal range of AV node. So this is called as paroxysmal nodal tachycardia. Now we will come to ventricular rhythms. In this section, we shall study idioventricular rhythm, ventricular tachycardia and ventricular fibrillation. This ECG shows a very slow rate of 32 per minute. This is a ventricular rate. A ventricular pacemaker's rate is between 20 to 40 per minute. Now let us observe the beat closely. There is no P wave. The QRS complex is 3 mm wide, suggesting ventricular beat rather than supraventricular. A mid-nodal rhythm would also be very similar without a P wave, but the rate will be between 40 to 60 per minute. This is idioventricular rhythm. There is absence of P wave, wide QRS complex and rate between 20 to 40 per minute. In this ECG, the QRS complexes are very rapid but broad and bizarre, indicating that the impulses are originating in the ventricles. There are no P waves. RR interval measures 6 small squares, that is the ventricular rate is 250 per minute. This is ventricular tachycardia. It is common after myocardial infarction due to formation of circular circuits around the ischemic area. It is very alarming as it will lead to ventricular fibrillation and death. This ECG shows no proper QRS complexes. There are just coarse, chaotic undulations. This is ventricular fibrillation. It has to be corrected immediately with DC conversion shock, otherwise death will occur. Note the coarse undulations of ventricular fibrillation. Note the wide QRS complexes occurring very regularly at a rate of 75 per minute. This is a pacemaker rhythm. Since the pacemaker is placed in ventricles, the QRS complex is wide like ventricular beat. Now note the P waves. P waves are seen at regular intervals and bear no relation to the pacemaker rhythm. The condition is complete heart block on pacemaker. We will be studying the heart blocks in the next chapter. Now in the chest leads of the same ECG, we can see a spike of pacemaker stimulation termed as pacemaker spike. Note the deep vertical spike followed immediately by a wide QRS complex. WPW syndrome or Wolff-Parkinson-White syndrome. Whenever PR interval is shorter than 3 small squares, we must rule out WPW syndrome. Now let us observe this ECG closely to study the features of WPW syndrome. The PR interval is very short, just 2 small squares. There is no isoelectric line between the P wave and the QRS complex. The R wave starts immediately after the P wave and the QRS complexes is wide, almost 3 small squares wide. Now study the QRS complex more carefully. You will notice that only the initial portion is wide and slurred. The downstroke of the R wave and S wave are perfectly normal. This slurred upstroke on the beginning of the R wave is called as delta wave. The delta wave is seen in those leads which show a tall R wave, usually in lead 1 or V6. It is accompanied by an inverted T wave which is opposite in direction of the QRS complex, indicating abnormal ventricular conduction. Whenever ventricular conduction is via the normal pathway, the T wave is in the same direction as the QRS complex. The slur of WPW syndrome is also seen on the downstroke in the leads showing a predominantly negative QRS complex. Note the slur on the S wave in V1 and the absence of PR segment. It is important to know the presence of WPW syndrome as it often leads to serious tachyarrhythmias in later life. The isoelectric line between P wave and QRS complex is due to the AV nodal delay. But in WPW syndrome, the impulse leaks to the ventricles via an accessory bundle of fibers called bundle of Kent. So the isoelectric line between P wave and QRS complex is replaced by a slurred upstroke. This is another ECG of WPW syndrome. Note the delta wave and inverted T wave in leads V5. Again slur on the upstroke of R wave in lead V6. And in lead V1 there is negative QRS complex with slur on the downstroke of S wave. Now note the limb leads. Positive QRS in lead 1 and negative QRS in lead 3. That is, there is left axis deviation. WPW syndrome is of two types, type A and type B, also termed as V1 positive and V1 negative. In type A, the accessory fiber of bundles is on the left side. It causes a positive QRS complex in lead V1 and right axis deviation. In type B, the accessory fiber of bundles is on the right side. It causes a negative QRS complex in lead V1 and left axis deviation. This ECG shows negative QRS in V1 with left axis deviation. So this is WPW syndrome type B. AV block, complete and partial heart blocks. First degree AV block or first degree partial heart block or a block in the AV node. In this ECG, measure the PR interval. It is 6 small squares or 0.24 seconds. Normal range for the PR interval is 3 to 5 small squares. So this ECG shows prolonged PR interval indicating delayed conduction from atria to ventricles. But no beat is dropped. This is termed as first degree AV block or first degree partial heart block. Note again in another bit PR interval of 6 millimeters, and note in the lower strip that every P wave is followed by a QRS complex. Only the conduction is delayed in the AV node, resulting in prolonged PR interval. Here is another ECG with a PR interval of 8.5 small squares, that is 0.34 seconds. All P waves are followed by QRS complexes. This is first degree heart block. Now we come to a third degree heart block. Observe this ECG. You can see P waves at regular intervals at a rate of 100 per minute, and there are QRS complexes also at regular intervals at a rate of 30 per minute. But there is no fixed relationship between the two. That is, the atria are beating to their own sinus rhythm and ventricles are beating to their own ventricular rhythm. Impulses are not going across the AV node to the ventricles. So this is third degree AV block or complete heart block. In this rhythm strip, we see P waves occurring regularly at a faster rate and wide QRS complexes occurring regularly at an independent slow rate. This is total heart block with ventricular rhythm. Note the regularly occurring P waves. This is another ECG of total heart block. Identify the regularly occurring P waves. Wide and slow QRS complexes are obvious. Once again, note the regularly occurring P waves and independent slow wide QRS complexes. So in total heart block, there is no conduction from atria to ventricles and each beats at its own rhythm. This is another ECG of total heart block. Identify the atrial rhythm and the ventricular rhythm. Second degree heart block. Between first degree heart block, where the AV conduction is merely delayed, to third degree heart block, where there is no conduction at all through the AV node, we have second degree heart block or second degree AV block, where only intermittently a few beats are not conducted across the AV node. On ECG, as we will see in the next three examples, some of the P waves will not be followed by QRS complexes. Now let us see different types of second degree heart block. In this ECG, we see that some intermittent P waves are not conducted. So first we must see whether the PR interval is constant in all the beats or it varies from beat to beat. Here it varies from beat to beat. Now let us observe the pattern more closely. In the first beat, the PR interval is 4 small squares, that is normal. In the second beat, it is 6 small squares. In the third beat, it is 7 small squares. and the fourth P wave is not followed by QRS complex. This phenomenon, where the PR interval gradually increases till a beat is dropped, is termed as Wenckebach phenomenon. Then again, the next beat will show a normal PR interval and the process will continue again. Note this strip. The first PR interval is 6 millimeters, the second PR interval is 8 millimeters, and the third beat is dropped. This is Wenckebach phenomenon. This is because each successive impulse arrives earlier and earlier in the refractory period of the AV node and takes progressively longer time to penetrate the AV node. At last, a beat is dropped and the pause that occurs allows time for the AV node to recover, and the next PR interval is again normal. Watch the close-up view now. The first PR is 4 millimeters, second is 6 millimeters, third is 7 millimeters, fourth beat is dropped. Again the PR interval has returned to 4 millimeters. This is typical Wenckebach phenomenon. Note again beats 1, 2, 3 and 4. 4 millimeters, 6 millimeters, 7 millimeters and a dropped beat. Now we come to another type of second degree heart block, that is Mobitz type 2. This ECG shows wide QRS complexes of bundle branch block pattern. They are not ventricular ectopics because each QRS is preceded by a P wave indicating sinus rhythm. But intermittently, a P wave is not followed by QRS complex. So this is second degree AV block. Now measure the PR intervals, especially before and after a pause. They are normal. Second degree AV block with normal PR intervals and wide QRS complexes is termed as Mobitz type 2 block. Here the block is below the AV node in the bundle branches. Hence the QRS complexes are wide. And since the AV node is normal, PR intervals are also constant. Only intermittently a few beats are dropped. This is Mobitz type 2 AV block. Fixed ratio AV block. The third type of AV block has already been studied by us with supraventricular tachycardias. Here the ventricles respond to every second, third or fourth impulse, giving 2 to 1, 3 to 1 or 4 to 1 AV block. This ECG shows a QRS complex following every second P wave. This is 2 to 1 AV block. This is a fixed ratio AV block. The PR interval is normal and constant. Now we will come back to the ECG of third degree or complete heart block. Here the P waves occur at a rate of 100 per minute and the QRS complexes occur at a rate of 30 per minute, which is a rate of ventricular pacemaker. The QRS complexes are also wide and bizarre, indicating ventricular origin. So this is a total heart block with ventricular rhythm. In contrast, here is another ECG with third degree heart block. The P waves occurring regularly at a rate of about 100 per minute and QRS complexes occurring at a rate of about 47 per minute. Also the QRS structure is normal. This is a nodal rhythm. AV node beats at rates of 40 to 60 per minute. So this is a third degree AV block with nodal rhythm. This means that third degree AV block may have a ventricular rhythm or a nodal rhythm. Note the difference in the QRS structure and difference in QRS rate in ventricular rhythm and nodal rhythm. In this ECG, the P waves are seen regularly every 13 millimeters and wide QRS complexes at every 44 millimeters. That is, the atrial rate is 115 per minute and ventricular rate is 34 per minute. So this is complete or third degree AV block with ventricular rhythm. Note in close-up view the wide QRS complexes and regularly occurring P waves. Compare it with idioventricular rhythm below, where the QRS rate and appearance is similar but there are no P waves. In total heart block, the SA node is functioning, so P waves are present, but the impulse is not reaching the ventricles across the AV node, so ventricular rhythm has started. While in idioventricular rhythm, the SA node itself is not functioning, that is, there is sinus arrest, so there are no P waves and ventricular rhythm has started as an escape rhythm.